So this is the taping for the ACL and the MCL in the knee, okay? So we get the patient in standing with slight flexion, about 20 or 30 degrees in their knee, as shown. Now for the purposes of this, we are going to use UNDERWRAP underneath because we don't want to pull the hairs out. And for the purposes of the exam, you will be allowed to use UNDERWRAP. However, if it was a patient, we would expect them to shave this area, okay, either using clippers or using a razor, and they do it themselves so that there's no hair, so you're applying the tape directly onto the skin. So for the purposes of the exam and for today, I'm just going to use some UNDERWRAP and wrap it around the knee like so. Okay, now for the taping, what we're going to use is we're going to work our way around and say this is a supportive one for the MCL. So again, just slight flexion there within the knee, okay? We're going to start on the outside, just above the head of fibula, around there. Okay, we're going to wrap around with minimal tension in the EAB. So we've got 7.5 elastic adhesive bandage as we come around the base, okay, of where we've just gone before. And then, as we then going to do the tension, we're then going to pull with some tension up and diagonally back. So the tension is here, and I'm pulling that way. As I then come up to the top, like so, above the kneecap. So I'm above the level of the kneecap here. And then as I come round now, I then go diagonally down and cross at the inside of the knee with minimal tension. The tension's not really here. And then going to wrap around again, around the base with minimal tension. And then I'm going to repeat what I did the first time with another tension. So I'm going to apply some tension onto the tape, pull it up and round, like so. And then I'm going to go round the thigh once and then cut it. Okay, so round the thigh like so, with no tension, and then cut on the outside of the knee round here. And that is the ACL taping. Once you've applied the tape, you need to check for sensation distally. So to the taping, make sure that the sensation is normal, there's no pain or no pins and needles. Check the capillary refill, so there's no significant colour changes. And also check that there's no swelling that has developed after the taping. The taping for the medial collateral ligament on the inside is applied on top of the ACL taping for the purposes of the exam. We already have our anchors or fixators here because we've already applied them with elastic adhesive bandage 7.5 centimetres around the lower end of the thigh and the upper end of the lower leg. So we can apply our strips of tape on top of this. Now the first two pieces, what we need to do is get the knee to bend in about 30 degrees of flexion in the knee. We're then going to apply strips of 5 centimetre elastic adhesive bandage diagonally across. So we're going to measure it and then cut it, okay? So we apply it to the top, tension now down diagonally like so. The other one we're going to place exactly the same in terms of tape and the length of it, but this time we're going to come from the front part here of the tibia, tension and diagonally backwards and apply to our anchors. Over the top of this, we now apply 2 pieces of zinc oxide, 3.8 centimetre tape, in the same fashion from the anchor at the top with some tension. And now we're going to apply a little bit of varus force, okay? So we're going to try and push the lower leg with our leg inwards, like so, while we're applying the tape. So I'm pushing there to try and get a little bit of a varus force going on in the knee, okay? to support the ligament. So once again, place it on there and then push inwards like so. There's 2. And again, get another piece measured. Place on the top one, slightly overlapping. And again, apply a bit of pressure on the outside of the foot, like so. And then final one, another piece of 3.8 zinc oxide from the top attachment there, a little bit of a varus force, like so. So you have 6 pieces of tape, 3 that way and 3 that way. What we now need to do, before we lose too much of the tension, is reapply the anchors. Now the anchors are applied without any tension whatsoever, okay, just around the top, so there's no tension in those. And then we cut there, and then we apply another one around the bottom, again with no tension, okay, and again we cut it. And that's the finished ACL and MCL taping. Once we've applied the MCL taping, we need to once again check distally in terms of change of sensation, in terms of pins and needles or pain, change of swelling, has there been an increase in swelling, and change of colour, and make sure that there is still capillary refill when we press the skin here, as you can see there is. For the wrist taping, for the purposes of the exam, we are going to use UNDERWRAP, but I would advise, if this is a patient, to ask the patient to clip or shave the hair on the back of the hand and the forearm, so we're applying the tape directly onto the skin. So for the purposes of the exam and for this video, I'm going to use some UNDERWRAP just to cover this area. Just open your thumb for us, okay, just so that we protect the hair. Like so. Now when we're using the anchors, okay, we're going to use an anchor here, an anchor here and an anchor here. The anchor here needs to be elastic adhesive bandage because we are going around muscle. Here we don't need it to be, and here we don't need it to be. So we're going to use 5 centimetre EAB with no tension at all as an anchor at the base. We're then going to apply an anchor of zinc oxide just proximal to the radial styloid there. Okay, so just proximal to the wrist joint. Again, with definitely no tension here. Do not tighten this one because there are lots of tendons and blood vessels and nerves that run through here that you do not want to compress downwards. We're then going to put a third and final anchor at the top like so, which is going to wrap around the fingers, and again just press it down, but again normally without the UNDERWRAP this would press directly onto the skin, so it would stick very well. So they are your 3 anchors that we're going to use. We're then going to use a fan, so we're going to fan the tape, measure it. Now we want to try and prevent the patient from hyperextending, because that's, for the purposes of this, is what the injuries happen, where the wrist is hyperextended, so we want to try and protect that. So we're going to put the wrist into slight flexion, like so. We're then going to place an anchor at the proximal end, put some tension. We don't need too much tension because the movement's going to provide that anyway. And then anchor it down there and there. We're then going to apply a second strip, measure it, and then from the proximal end, like so, we're going to again go onto the anchor here, and the crossing is at the wrist joint. And then we have a second strip, and we're going to do 6 of those, 3 each way. So once again, and just slightly changing the position of your tape each time, just so that we really incorporate all of the wrist area. Okay, so there's one that way, and again we're going to put another one going the opposite direction, and again with slight flexion still, and just maintaining there. And then finally, the last kind of two, which go more centrally. And again, like so. And final one, again measuring each time and ripping the tape for speed of application from the proximal there and lay it down into here. Okay, before the patient then changes their position, we're going to anchor with 5 centimetre EAB with no tension again at this part. And we're then going to use zinc oxide, 2.5 centimetre, as an anchor here with no tension. And then the final anchor is proximal, is distal here, around the metacarpals. And what should happen now is it prevents the wrist from extending because the tension is on the inside. Now, we could also do this wrist taping and put it on the back to prevent hyperflexion. However, most wrist sprains happen in that direction. Once we've applied the tape, it is very important that we check for changes in colour in this area. So we're looking for capillary refill again to check that there is refill of the colour change in terms of the blood here. We also need to check that there's no extra swelling, and we also need to check there's no change of sensation in terms of pain or pins and needles in the fingers. And especially in this area, you can cause compression in the wrist, in the carpal tunnel part of the wrist, which can sometimes cause changes in terms of pain and also sensation. So just make sure you check this before the patient leaves your clinic. The second part of the taping was we're going to do a figure 8 essentially onto the wrist area. For this we're going to use 5 centimetre elastic adhesive bandage. We're going to start where the proximal anchor was, okay, and we're going to just now wrap around the wrist as we work our way up, about half. We're covering half at a time, okay. Ask the patient just to move their thumb out of the way, again with slight flexion because we want to keep that tension to make sure they don't fully extend. We're then going to come around and then we come diagonally up the back of the wrist like so. Then as we come over, we're going diagonally into the palm of the hand again. We then go, and we've got to now bring in, as we come around the wrist, because we need to, as we've come around here, because we're covering all the skin like we did in the ankle taping, okay? And now we need to come diagonally up to the base of the thumb. Okay, so the base of the first metacarpal there, as again we come diagonally around the wrist and then back down, okay, again with slight flexion, back down the inside of the palm and then around the base, and then we finish. Okay, once we've applied the taping, it is important that we check for changes of sensation, changes of colour, and any extra swelling that might have developed since we put the taping on. And make sure that we give the patient these warnings to look out for when they leave your clinic. And that is the wrist taping.
So the first thing we need to do to ensure that the ankle is ready to be taped, we need to make sure that the area has been shaved. This is really important. First of all, for when you put the tape on, it might move around on top of the hairs, but also when you remove the taping, it will pull all the hairs out and be very uncomfortable for the patient. So ideally, you want the area that you're going to be taping to be shaved completely. The second thing is to remove all oils and all creams and lotions and dirt from the area, so you wash the whole area. This will affect the adhesive and mean that it doesn't stick so well. And the third thing, which is really important, is to ensure that there are no cuts or lesions or open wounds or anything like that, because they all need to be covered before you apply the tape. Otherwise, when you remove the tape and the adhesive will pull at the cuts and make the cuts worse and may make the area bleed. So it's really important you prepare the area before you're going to be taping. So the first stage we're going to do now is putting an underwrap, and what we need to do is make sure that the patient keeps the foot pulled up and maintain that position throughout the period of the strapping. We're then going to get the underwrap roll and we're going to place it onto the ankle. Now the roll is against the foot, okay, so it's not the other way where it's on top, it's actually, it rolls onto the foot. You place it on the outside of the ankle joint, get it nice and flat, place it there, and then we're going to come around underneath the sole of the foot, and all I'm doing is rolling it between my two fingers, rolling it against the foot, the contours of the foot. I'm not putting any tension on it. I'm making sure it's not too loose, but I'm literally just rolling it in figures of 8 around underneath the heel and then up across and around to the top above the ankle, and just keep working round in figures of 8, making sure that they maintain the foot position, working round with no crease or minimal amount of creases as possible, and then we wrap around the top, and it should be nice and smooth, and the underwrap shouldn't be rolled up at all or no creases, otherwise that's where you will get blisters. And that's how it should finish off, and that's what it should look like with underwrap on the ankle. Now for the second part of the ankle strapping, we're going to use the elastic adhesive bandage, which is adhesive on one side and is stretching one direction but doesn't stretch in the other direction. Very similar to the underwrap, we're going to place it on the outside of the ankle, get the patient to keep their foot up, and then we're going to come over the top, underneath the sole and back round again. We complete it round. We're then going to go a little bit further towards the back of the ankle. We're going to put a little bit of tension on now, come up across the front of the ankle and round the top. We're then going to go down towards the sole again on the inside of the foot, come round underneath the sole again, up across the outside of the ankle and across the front again, around the top, and just keep doing figures of 8, working round the ankle until eventually we fill in all of the gaps, especially around the back of the ankle, around the Achilles. And we work all the way around, down under the sole again, and then we come up round the top and round, and we finish at the top on the inside. We just check the ankle strapping itself to make sure that there's no gaps and there's no creases in any of the taping, and this means that there will hopefully be no blisters or any kind of rolling of the ankle tape. We then use a pair of scissors to cut the inside of the tape around the top, and there we have a figure of 8 ankle strapping. What we must make sure we do once the ankle strapping is finished is check the colour and the sensation of the toes distal to the ankle strapping, and ask the patient to make sure they've got no pins and needles or pain after the strapping's been put on. Otherwise the taping would have been put on too tight and we maybe need to loosen it. This is very important, and it's important to give the patient the advice after the strapping's been put on to ensure sensation stays the same. And this is so for the stirrups, what we're going to do here is place an anchor around the top of, just above the ankle. This is using zinc oxide 2.5 centimetre. There's no tension on the anchor, it's not put round tightly, it's just literally laid onto the skin. We're then going to put the stirrup, so we're going to start on the inside of the ankle, fixing to the anchor. We're going to come underneath the heel, underneath the calcaneus, pull the foot up, measure it to where it would attach to the anchor, rip it, and put a bit of tension and fix it down to the anchor. Okay, what you need to now get is a patient to keep the foot in the same position while we apply the second anchor, which is applied slightly in front of the other one, but still going underneath the heel. Measure it again and place it down against the anchor with a bit of tension. So the tension is on the outside of the ankle, and the third anchor goes slightly in front of the second one. Again, measure it, push it down onto the anchor, ensuring that the patient is keeping the foot pulled up. And we're going to make sure that the second anchor is put in place before we lose the tension in the stirrups. Now if we have a look, we've managed to go under the heel bone, under the calcaneus, and not into the soft tissue just in front of it. Otherwise this will become really uncomfortable for the patient and they'll end up having to take the strapping off. And this is the ankle strapping, the stirrups for the ankle. So for the last stage of the ankle strapping, we're going to do a full heel lock, and this goes on top of the stirrups and goes onto the figure 8 elastic adhesive bandage. We're using 2.5 zinc oxide, and we start on the outside of the ankle at the top of the strapping. And so it's about 2 or 3 inches above the lateral malleolus. We go across the front of the ankle, above the 2 bony prominences of the ankle, the medial and lateral malleoluses. So we go across the medial aspect of the ankle, and then we come back and then we come to the base of the Achilles where it inserts into the calcaneus. We then come down underneath the sole and underneath the calcaneus, underneath the heel, come up across the inside of the ankle, and we go across the front of the ankle joint again, parallel to the first strip that you put on. Then we go back towards the lateral malleolus, back towards the heel, and you cross at the same point behind the heel. You then come underneath the heel again, and then come up across the outside of the ankle, across the front, and then we come around the top and we fix at the top. And that is the full heel lock, which prevents too much movement and it prevents most support to the ankle strapping. And then we must make sure that you check the circulation and check the sensation of the toes and the distal part of the foot to make sure the patient understands if they get any pins and needles or any change of sensation, or they see the foot go red or swollen, then they need to make sure they cut the strapping or release it. Otherwise this can cause problems. And that is the full ankle strapping with a heel lock.